Okay, so here we got a patient with a bonded hyrax, and we want to procline those or move those upper incisors as mesial as possible. So what we want to do is put a rigid wire into her mouth and lock these 4 teeth together, pushing them en masse, hopefully moving a point mesial. We want to put Pushcoil between the bonded hyrax and the lateral incisor. Lateral incisor and the tube on the, close halfway. And the tube on the bonded hyrax. Okay, so let's undertie these front 4 teeth together so we move them en masse, and we'll put a bit of Pushcoil, so it is very lightly active in those spaces. So we undertie in the figure 8. And this ensures we don't get rotation of the lateral incisor. Otherwise, if we don't place this undertie and we activate the coil, what will happen is the lateral incisor, the distal part of it will kick buccally. So you'll cause a rotation which you'll have to correct at your next visit. It may even slow down the case. So undertie, make it nice and tight. We also squeeze it in between the teeth. We cut, leave about 4 or 5 millimeters of ligature wire, like so, and we'll tuck that away. Always tucking gingival, just because patients, when they eat, food impacts in this direction, hence the wire is less likely to be moved. So if you tuck in a occlusal direction, when the patient eats, they chew on food, and the wire will, instead of sitting nicely like this, will eventually come out and lie towards the buccal, causing you a little emergency. Okay, so the way we place our coil, we place it accurately. So we measure. We get these rules that we've cut, and we can measure from the flush from the tube on the hyrax up to the distal of the lateral. So in this case, if we go to say 32 millimeters, that will give us ample coils to not only cover the space, but actually compress the system, compress it a little bit, so it provides a force on this direction, on the incisors. On this side, on the right side, we will, once again, same thing, measure between the mesial of the upper tube, and that's 20, 30, we'll go 32 again. So we'll do two equal lengths there of Pushcoil of 32 millimeters each. So my nurse will cut those and place those on my arch wire, which will be a 1925 stainless steel. We want a rigid arch wire so we don't distort the arch form. So we'll put the arch wire in their buccal tubes. And the trickiest part here is because the Pushcoil can get a little bit fiddly. But apart from that, it's a very simple procedure. And we just want it ever so lightly active because we're pushing against a very firm expander. So we then compress our coil as it goes through into the slot of the bracket. Close our gates, and the Pushcoil is trapped in that position, thereby wanting to expand to its original shape, and hence it is considered active. And you can see there that it's pushing on those teeth there. So on the opposing side, we'll do the same thing. And that's in there. So you can see that from, oops, popped out of the tube. Mirror. Turn your head to your left, please, just a little. Perfect. Pull the wire back in the tube. Okay, and you'll see that the push coil is touching my buccal, medial part of my buccal tube, and when it is fully stretched, it's the length of the bracket. So that's important because we activate the width of a bracket. So now I just compress that coil, get a tucker. You use a ligature director or a ligature tucker if you like to compress the coil, thereby activating it and then engaging the wire into the brace, the bracket. So you can see that push coil is active and pushing on that bracket. Two active push coils, left and right, pushing these teeth further forward to create more of a positive overjet wire together. That's already going to be an excellent face mask result.